Thank you all for being here today. My name is Julie Byerly, and I have the honor and privilege of being the president of Geisinger College of Health Sciences and the dean of our medical school, Geisinger Commonwealth. And, you know, long ago when our school was envisioned by the community members who founded it, one of the charges that we continue to embrace enthusiastically is to be a source of health-related education for our community and an opportunity for convening people who are interested in expanding the knowledge and awareness of health-related concerns. So it's with that perspective of enthusiasm and honor and seeing dreams of our founders fulfilled that I welcome you enthusiastically tonight to this special opportunity to think about colorectal cancer, its prevention, treatment, and a path forward for us. You know, each of us here has been touched, I'm quite sure, by colon cancer, and you'll get to hear some of those stories tonight of some who were very recently touched. But each of us brings a story, and the story I bring is having lost a paternal aunt and a paternal uncle to this illness and caring for a father who lives worried as the only sibling who hasn't faced that condition in his three-sibling set. So that means a lot to me. I know it means a lot to each and every one of you here as you think about the stories that bring us to this point in this place. I want to thank those of you who have invested in each of us and our stories, like in particular the city of Wilkes-Barre. We're so glad to have our mayor, George Brown. Thank you for being here tonight, and thank you for sponsoring and helping to convene this event. We also, of course, are grateful to the Northeastern Regional Cancer Institute, the NRCI, that is sponsoring this event and sponsoring Casual Day in just soon, and I'm modeling some Casual Day socks that I hear are in short supply, but you can talk to Karen about how you can get your own set. And then we also are, of course, grateful to the city of Scranton, and we see our Mayor, Paige Cognetti. Thank you for being here, Mayor, and thank you for the support of the city at this event. Quickly, I'm going to turn it over to Dr. Sam Leshko, who is the medical director of the Northeast Regional Cancer Institute. I also want to thank Karen Saunders for being here, and also Laura O'Toole, the executive vice president. Thank you for being here. And then all the many special guests who will be introduced as they have the opportunity to tell their stories. Thank you on the provider side, and thank you on the patient side, and thank you on the invested community member side for holding this space tonight so that we all can learn more about this condition and the individuals and families affected by it. Okay, Dr. Leshko, thank you for being here.
Thank you, Dr. Byerly. What I'd like to do now is just take us through the agenda very quickly, and then we'll get on with the program. We're going to begin by having three of our friends, neighbors, tell us about their recent experience with being screened for or treated for colon and rectal cancer. That will be followed by a panel discussion of four or five physician experts in the diagnosis and treatment of colorectal cancer. And at the conclusion of the panel, we'll have an opportunity to answer questions. We've had some questions submitted in advance. I have copies of those, but there'll be an opportunity for the audience to ask questions as well. We ask you to hold those questions until the conclusion of the panel discussion. So with that, I'd like to begin with the testimonials, and we'll begin with Dr. Stopper.
Thank you very much, and thank you for the opportunity to speak here. I'm actually much more comfortable with slides and being over there, but that's not why I'm here tonight. I'm here to speak with you as a patient and someone who has been screened for colon cancer. My story really starts several years ago when I got to know Alessandro, who you're going to hear quite a bit more about, I'm sure, in a little bit. We were introduced through a mutual friend, and we used to run together at Lackawanna State Park on Sunday mornings. When he was diagnosed, of course, that came as a shock to everyone. And I supported Casual Day, and every year I would get my shirt, and I would proudly wear my shirt. And then 2 years ago, when I was 45, I got my shirt, and anyone who's gotten the shirt, you get the printout on the front. It says, you're at higher risk for colon cancer if you have these issues. One, of course, being age 45, and I'm somewhat embarrassed to say that I don't think I even knew at that point that the screening recommendations had been shifted to 45 years old. Second, of course, was if you have a family history of colon cancer. And in my recollection, I remember that my grandfather actually at the end of his life was diagnosed with colon cancer, although that is not what he passed away from. So at that point, I realized that I am in a category where I should clearly be screened. I had probably been to a doctor in about 4 years at that point. So I made an appointment with the primary care doctor, and my primary care doctor recommended Cologuard. So I dutifully took my happy little Cologuard box to the UPS store and sent it in, expecting that in a few days I would get a negative result, but lo and behold, it was positive. So as every cardiologist probably does, I Googled Cologuard, not knowing anything about what the actual likelihood of a positive Cologuard being indicative of colon cancer was. So I was happy to learn that it was not actually particularly high. It's only about 4 or 5%. However, a lot of people who have a positive Cologuard will end up having a polyp or something else that needs to be addressed. So about a month later, I followed up with a colonoscopy. And my colonoscopy showed that I had about a 2-centimeter polyp, which is a pretty large polyp. And at that time, I was age 45. So they removed it. They were able to remove all of it. And thankfully, it was not cancerous. I got a tattoo out of the situation inside so that they could go back and look at that same spot a year later. And I'm happy to report now that I've had my year follow-up and everything was clean. There was another small polyp that was removed, but the point is, if it weren't for Alessandro and if it weren't for the work that's done by this committee and the folks in this room, it could be a very different story. I mean, I'm sure that the panel can tell you what the chances of a large 2-centimeter polyp is to progress to colon cancer over 5 or 6 years, which is probably when I would have gotten around to being screened if it hadn't been for the raised awareness of the people in this room. So I'm very thankful for that, and I would absolutely encourage anybody in this audience, if you are 45 or family history or know anyone who might be at higher risk, get screened. It's really not a big deal, and it can prevent so many issues down the road. Thank you.
Thank you, Dr. Topper. Our next speaker is Amy Kearney, who has her story to tell.
Hi, my name is Amy Carney, and I would like to share with you a little bit about the last few years of my life. Never could I have imagined 2 years ago I would be standing in front of you today talking about my recent cancer diagnosis, treatment, and surgery. In October 2022, I was having the weird symptom of not being able to swallow. My friends convinced me to call my doctor. At that visit, he sent me for blood work, which found out my hemoglobin was dangerously a 5.2, and I would require a blood transfusion. After that, an endoscopy and colonoscopy followed, which revealed I had a stage 2 rectal tumor. I had an aggressive course of chemo and radiation, but ultimately had to have surgery to remove everything and receive a permanent colostomy. Throughout my treatment and surgery recovery, I was out of work for the entire year of 23. One piece of advice I would give someone going through a similar situation would be to stay positive and take it one day at a time. Set small goals for yourself and celebrate the little victories. I always say I look for my silver linings. I have learned so much from what I have been through. The little things don't bother you as much, and you just appreciate life so much more. I have 2 daughters, and throughout my journey, I had to show them that I was going to fight and get through this. It would just be a bump in the road, and we would all get through it together. I'm fortunate to have an amazing family and friends that make up my support system. They did not leave my side the entire time. I'm not usually someone that would have talked about something so private, but this has shown me that I need to speak up and become an advocate for regular colonoscopies. Colonoscopies are so very important because we can actually prevent a type of cancer that has changed my life forever. My message is to please not ignore the simple signs or crazy symptoms you may be experiencing. Don't be afraid to speak up and see your doctor to get checked. If you are not satisfied with the care you receive, I suggest you try and find another doctor. And if you're 45 and older, please go for regular colonoscopies and doctor appointments. They recently changed the age for routine colonoscopies from 50 to 45. My siblings and children were told they need to have theirs 10 years before my age of diagnosis, which is 35. If I had missed these crazy signs, I would not be here today.
Thank you, Amy. And our next presenter is Gail Smeraldi.
My husband, Alessandro Smeraldi, was diagnosed with colon cancer in April 2020 during COVID. He was 47 years old at diagnosis and hadn't been feeling the best for a couple of weeks. He, of course, put it off, just like many of us do, and just chalked it up to his busy life as a vascular surgeon, the craziness of working as a healthcare professional during COVID, and being a husband and a father to our two kids, who at the time were 11 and 14. Unfortunately, on April 21st of 2020, they did find a tumor in his colon, and ultimately he had surgery to remove the tumor. He was on chemotherapy for a few months, back to work as a surgeon, and doing well overall. A follow-up scan showed a liver metastasis in November of 2021, and he also had that removed. He continued with life and work and followed up with all the physicians involved with his care. Unfortunately, his disease continued to progress, and he ultimately lost his life on February 9th of 2025. I will say that he won the battle, as he fought hard and lived such a great life with both of our kids, who are now 19 and 16. He was able to spend the last year and a half at home with our kids, just enjoying the time together and making all of the memories that will last a lifetime. Colon cancer can affect anyone. Our daughter said last year during the Casual Day video that colon cancer doesn't discriminate, and I find that to be true. If you are 45 years or older, please get screened. Talk to your primary care physician about any symptoms that you might be having. It is a very important discussion to have with your doctors, but as well as with your family members. Alessandro did not have a family history of colon cancer, and at the time of his diagnosis, the age to be screened was still 50 years old. Now that age has dropped to 45. Both of our kids will now get screened at age 37, which is 10 years prior to their dad's diagnosis. I can't tell you how important the open discussions are with your healthcare providers as well as your family. Alessandro was lucky to have his healthcare providers as his friends and colleagues. Not everyone is in that position, and that is why it is so, That's why it's so important to be an active participant in your own healthcare. Ask questions and get the answers. This panel was Alessandro's mission for this year's Casual Day. He wanted a panel of his friends and colleagues to come together to discuss colon cancer and how to navigate if you or someone that you love receives this diagnosis. He was literally on a call with the Northeast Regional Cancer Institute about this panel the day prior to him entering hospice. It was that important to him, and now my kids and I will keep spreading the message and getting the information out to the community. I would like to thank Geisinger and the NRCI for working together to make Alessandro's vision this year a reality. He would be very proud to see it all come together and know that he is still making a difference. Thanks to the panel for your information, your expertise, your time, and of course your care of Alessandro during our journey with colon cancer. Get screened. It may save your life or somebody's that you love. Thank you.
Thank you, Gail, and thank you to the three of you for sharing your stories with us. It makes it more personal, and I'm an epidemiologist, so I deal with the numbers. You bring the person side to this, and that's an important piece of the story that's easy for me to forget, but I don't want anybody in the audience or in the community to forget that. This is important, and thank you so much for sharing your stories with us. Now, I'd like to ask the other members of our panel to join me up on the stage. We have Dr. Chris Peters, Dr. Jay Bannon, Dr. Michael Kondash, and Dr. Amber Sabuto. And if I may, I'll sit in the middle. And I'm told that these mics will work, so we're fine. So I'm going to begin by talking about the epidemiology of colon and rectal cancer and some of the risk factors for that. So to make sure we're all on the same page, I'd like to just give a quick definition of cancer. It's not a single disease. It's more than 100 diseases that affect a variety of organs, well, virtually all organs in the human body. The common feature is uncontrolled growth of abnormal cells. And left uncontrolled, those cells will escape the tissue of origin, the organ, and spread to other organs and tissues. Cancer is a genetic disease, and by that I mean that the DNA gets mutated, that there are changes in those molecules that control how cells function. They control how the cells function, how they multiply, and how they behave. By calling cancer a genetic disease, we can refer to it as a heritable or an inherited condition, meaning it's passed from parent to child, but it can also be acquired during a lifetime. So even if you do not have a family history of a heritable condition, the cancer can still develop in our lifetimes. So this is Colorectal Cancer Awareness Month. So here are some of the figures for colon and rectal cancer in the United States. It is the 4th most commonly diagnosed cancer. Each year in the United States, or this year in 2025, we expect about 154,000 Americans to be diagnosed with colon and rectal cancer. It's the second leading cause of cancer death in the U.S. About 53,000 of us will die from colon cancer this year. The rate of death is 13, meaning 13 out of every 100,000 in the U.S. population are expected to die from colon cancer this year. If we turn our attention to Northeast Pennsylvania, the figures look fairly similar. It's the 4th leading cause of cancer in Northeast Pennsylvania. Here in our home area, about 500 patients will be diagnosed with colon cancer this year. An important difference is that rate, that incidence of colon cancer in Northeast Pennsylvania is 14% higher than the national average. Doesn't mean it's the highest rate in the country, but it's significantly higher than the U.S. average. Colon and rectal cancer is the second leading cause of cancer death here in Northeast Pennsylvania. About 200 or slightly fewer of our neighbors can expect to die from colon cancer this year. The death rate is also higher than the national average. In this case, it's about 17% higher than the U.S. average. So we're in a high-risk neighborhood, a high-risk community. Let's talk for a minute about risk factors. These are personal characteristics that increase your risk of developing a disease, in this case, colon cancer. I've already alluded to the fact that there are some hereditary syndromes, one of which is familial adenomatous polyposis. It's a lot easier to say FAP. People who inherit this condition develop a large number of warty growths in their large intestine, and they have an extremely high risk of developing colon cancer. Another hereditary condition is non-polyposis hereditary colon cancer, or HNPCC. Still easier to use the letters than the full word. But that syndrome is also called Lynch syndrome, and that's associated with a higher risk of colon and rectal cancers, but not a higher risk of the polyps that are seen in the other syndrome. There are several other cancers that go along with colon cancer in the Lynch syndrome, including endometrial cancer, ovarian cancer, and a few others. So there are hereditary syndromes. It's important to know that history and to share it with family members if you're aware of that in your parents, grandparents perhaps. A family history of colon cancer itself, even in the absence of any of these inherited syndromes, increases your risk for colon cancer, as does a family history of large adenomas, those polyps that can grow quite large in the colon. Age is also a risk factor. In general, colon cancer risk increases with advancing age. On average, patients are diagnosed around age 66. But more than 12 or 13% of colon cancer cases today are diagnosed in patients younger than 50. So that's a dramatic change in the effect of age on the risk of colon and rectal cancer. In the last 20 years, the number of patients younger than age 50 being diagnosed with colon cancer is virtually doubled. We may say more about that a little bit later. Sex and race are also risk factors. Colon and rectal cancers are a bit more common in men than women, but neither sex is protected. Colon and rectal cancers are a bit more common in African American and Native Americans, Alaskan Natives, than Caucasian population. A personal history of inflammatory bowel disease, Crohn's disease, ulcerative colitis, contributes a substantial risk for colon and rectal cancer, as does obesity and diabetes. Diet's a factor as well. Diets that are low in fiber increase our risk. So a high fiber diet would be protected. Diets rich in processed meats. I'm thinking hot dogs right now. That increases risk, as does tobacco and substantial alcohol use. Radiation to the abdomen and pelvis, perhaps for previous disease or maybe even a previous cancer, also increases risk. I have exercise on my list, not because it increases risk, but exercise is a negative risk factor or a protective factor. So regular exercise can in fact lower the risk of being diagnosed with colon and rectal cancer. Let's stop for a minute and talk about signs and symptoms. And Dr. Sabuto, I'm sorry, I stole
okay.
part of your
It's
slide
all for
here.
you.
The most important symptom for colon and rectal cancer is the top one on my list, none. The disease may develop silently, without any symptom at all. And that's an important thing to remember when we talk about screening for colon and rectal cancer. You don't need any symptoms to justify being screened. In fact, you should not have symptoms to be eligible for screening for this disease. But there are some symptoms that you should not ignore. Blood in or on the stool, a change in bowel habits, new onset of constipation or persistent diarrhea, abdominal pain, weight loss that's not intended. We often look for and hope for weight loss, but unintended weight loss or unexpected weight loss should be an alert and a sign to discuss with your doctor. Anemia, typically from iron deficiency, losing iron from blood loss through the colon, and the associated symptoms, fatigue, weakness, are all symptoms of colon cancer. But let me reiterate that the most important one on my list is none at all. So the fact that you do not have symptoms is not a get-out-of-jail-free card. Let's talk for a minute about colon cancer screening. This map shows the 8 health districts in Pennsylvania. We all look at Northeast Pennsylvania, and the prevalence of screening for colon and rectal cancer in the 50 to 75-year age group is 68%. Unfortunately, that's the lowest in the state of Pennsylvania. Pennsylvania average is about 75%. The US average is about 72%. So we have high rates of colon and rectal cancer in our community, and unfortunately, to this point, we're not screening as often as we should. One last comment about this slide is the rate I just quoted is for people aged 50 to 75. So the slide is based on data from 2020, so that's a little bit out of date. That's the most current I could find, but it reminds me that the recommendation for screening has changed to begin screening for average risk, asymptomatic subjects at age 45. Maybe we can make an argument that we should start it even earlier. So certainly for some folks, that's probably entirely appropriate. So that's what I'd like to conclude with and go on to Dr. Conde.
Hello, everyone. Honored to be here today with my colleagues and friends, and certainly to represent Northeast Regional Cancer Institute, which does a tremendous job for educating our community. I couldn't help to be touched by the testimonials. Thank you all for sharing that with all of us. Certainly, we all know friends and family that have dealt with this terrible illness, and it's just we have to do better at screening, just like Doctor said. So we'll move on from there. So these are the guidelines that are recommended, and you can see it's pretty much across the board that every large institution who deals in preventative health care has agreed that we should be screening people age 45 to 75. I think United States Preventive Service Task Force, CDC, Colorectal Society, American Cancer Society, everyone agrees on this. So, the mission is to make sure that all happens. There's also screening for age under 45. You heard Gail say that her children are going to be screened at age 37, and that's what the goal is, to get 10 years below the family member that has been diagnosed with cancer. Any children, first-degree relatives, would have to be 10 years below that. And like Dr. Lesko said, there's a number of other reasons to screen people even prior to that, even prior to 45, especially if they're symptomatic. He went through all of those, including the polyps, family history, and inflammatory bowel disease. And I think most of our patients understand that, who have those illnesses. They are schooled on that, and they really do follow up, I think, for the most part. For the older person, it really comes down to, what kind of life they live. A lot of people who are 76, 85, even older have very active lifestyles. They're doing everything that they did when they were in their 50s, and they can be screened as well. And we're fortunate enough to have other ways of screening without colonoscopy, because a lot of folks don't want to take a colonoscopy at that age because, of course, they're on other medications, including blood thinners, et cetera, et cetera. So I think, that's an individual type thing, and many times it's appropriate. So I think our older population should continue to be screened for the most part if they're healthy. We have some great options nowadays, that we didn't have before necessarily. On the non-invasive stool-based test, I should say, non-invasive, the newest thing that's out is called Cologuard. I think everybody has seen the ads on TV. Pretty catchy, and they do catch your eye, and you got to make sure you pay attention to that ad. And Dr. Stopper, you obviously had that experience, and it's what I do a lot all day. People come in for cough and a cold, etc. You're 45 years old, you haven't been here for 4 years, you have to get a Cologuard. And the biggest thing I tell people is when they get that Cologuard, I have a demonstration Cologuard in my office, so I show everybody it. It's good. It's not going to hurt you. It's okay. The demo is great. And I tell people to take it out of the box, put it in the bathroom, and don't move until you fill it up. Because most of the time, it ends up in the garage and it's gone. A whole year goes by, and people come back the next year or 2 years later. Oh, how's that cold? Oh, gee, I didn't do it. Okay, let's try again. Definitely. The two other tests that are non-invasive are the FIT and the high-sensitive guaiac test. These basically are looking for blood in the stool in a different way. One does it directly looking for blood, another one does it through an antibody test. They're also pretty accurate, but not as good as colonoscopy, of course, and probably not as good as Cologuard. Matter of fact, Cologuard in June is coming out with a new entity called Cologuard Plus. I think we're going to all see that. And it's close to colonoscopy in terms of specificity for diagnosing colon cancer, or more importantly, precancer. Whereas the FIT tests do not really screen enough for precancer. So polyps and precancer, not so much with FIT tests, but better than nothing. So a lot of people, through their health plans, et cetera, will get a FIT test in the mail sent to them because they see on the billing records you haven't had a colonoscopy or you haven't had a Cologuard. So this FIT test will come in the mail, and some people do it and other people don't do it. But it is better than nothing. So when you see that in the mail, if it comes from any entity, go ahead and do it. As far as the direct exams, colonoscopy, again, the gold standard, every 10 years is the highest rate of specificity. And, it's not for everybody, but it's certainly something to consider. It should be considered. If not, one of the other tests should be considered, but it is the gold standard. One of the problems with colonoscopy is access to care. We just don't have enough people doing colonoscopies right now. I think there's a large shortage in our country of physicians who are performing colonoscopies. We also have CT colonography. It's a CAT scan, basically, that looks to see if there's any polyps or any irregularities in your colon. And if you do, then you have to go ahead and proceed to a colonoscopy. Same with the others, actually. FIT and the two GUIAC studies, also, if they're positive, you must have a colonoscopy. So at the end of the day, if you really were going to pick something to start out with, it would be a colonoscopy. But the other things are okay. They get us to where we need to go, which is to screen. And then flexible sigmoidoscopy can also be done. It only goes halfway through the colon, doesn't really go the entire distance. And I'm sure as Dr. Bannon, Dr. Sabuto, everyone will say that a lot of colon cancers are on the right side of the colon now. So you don't really reach there for that. So it's kind of an incomplete study. Cologuard is one of those things that I think moving forward is going to be really important for us to screen with. Again, look out for that. Dr. Lesko mentioned some barriers. I mentioned just a few here. They happen every day when we screen people. I don't have a ride. I can't take off work. I'm fearful. I eat well, and I have no symptoms. I don't really need to do that. There's no one in my family who has it. So there's a whole bunch of barriers that, as a physician, you're trying to break through those every day. Sometimes you're lucky and you can, and on other times it just doesn't work out. So you have to hope that maybe another doctor or someone else, a family member, can get this person to do what they need to do. But I think we know about the barriers, so tough to break those down. And as far as advising people for colorectal screens, any type of physician, nurse practitioner, PA, certainly would be someone who we would want to advise people to get this done. Family members, friends, and neighbors. Obviously, people have had lots of experiences with friends and family that have colon cancer. Health systems like I manage, population management, like I mentioned before, send FIT tests out to be screened for their people who are in their plan. Industry leaders also, social media platforms, and basically anyone and everybody. So the message has to get out, and more, I think we have lots of chances to do that. Thank you.
Thank you. Dr. Bannon. Thank you very much. My name is Jay Bannon, and I'm a colorectal surgeon. I work here in Scranton in the Geisinger system. And I do a lot of different types of cancer surgery, but particularly colorectal cancer. And I'm grateful to have the opportunity to speak with you today. I want to first recognize Matt and Amy for their courage and standing up and telling their story. And part of the reason I'm here today is because of Alessandro Smeraldi, my close friend and former patient. Gail, what your family has done for awareness and how valiant Alessandro was in his battle, where he focused more on helping others and create awareness than on his own progression of disease was truly remarkable. And I remember him fondly, and it's hard for me to sit here recognizing that he's the one who invited me to be here just a couple of months ago and personally called me. And so I'm honored to be here. And this time last year, I just brought this as a prop, but I was wearing this with him, creating a video for awareness. And that's the kind of person he was, and I think he has made a clear impact in our community and will continue to do so. So, Gail, thank you very much. I also would like to thank Dr. I'd also like to thank Dr. Byerly, our host, for having us here this evening. Why are we here, really? And, you know, creating awareness is a very good thing, but there are a couple of key points to recognize. First is we can have a significant impact because colorectal cancer is common, and it is common in our area. So we're not talking about a disease that's rare and esoteric that you may not see. It affects many. And also, it is a preventable disease. And so if we have patients who understand what their risk may be and get screened appropriately, as Dr. Kondash has outlined, we can have an impact. And not only find the cancer early, but prevent a cancer from arising. And so when someone tells me they have a family history of polyps, I consider that the same as having a family history of cancer, because someone intervened and removed polyps before that individual developed a cancer. So it's important to recognize. We have something that we know of called the adenoma to carcinoma sequence. And not to be too scientific about it, but a polyp starts, which is a benign adenomatous polyp. And over a period of time, it degenerates into an adenocarcinoma or an invasive malignancy. We think that process generally takes 5 to 7 years on average, and in certain cancer syndromes, that rate may be a bit accelerated. And if we can screen people, do colonoscopies when they may be asymptomatic, but because they have a family history, and find polyps, we can remove polyps before a cancer even arises and keep that patient out of my operating room. And so that's a victory. And so that happens all the time. The good news is across the country that the rate of colorectal cancer is decreasing. And what that means is we're having an impact in screening and removing polyps. So there's less cancers being diagnosed. Our rate here in Northeast Pennsylvania is still high. And so we can do better, as Dr. Lesko has outlined. The concerning thing to me is that we're seeing more cancers as described at an early age. And so I see patients that have any family history at young ages with colon cancer, and though they may be the minority, that group is rising in number, and we don't really know why that is. But I see people in their 30s with colon cancer and no family history on occasion, and the youngest person that I operated on with colon cancer with no family history was 19. And so these things can happen. And myself and one of my partners, Dr. Tom Erchinger, who's here in the audience, who's a colorectal surgeon, can testify that we see people with colorectal cancer literally in our area on a daily basis. So it's common. The thing to know about all these screening recommendations are that it is for an asymptomatic individual. And so if someone has a change in bowel habits or some weight loss or something, they perceive a change, but they're not yet 45. That doesn't matter. The indication for surgery, or indication for screening, I mean, is to evaluate why one has those changes. And so don't wait till someone's 45 if there are some symptoms. If there's some symptoms that arise, even if it's in a younger individual, talk to your primary care doctor like Dr. Kondash, maybe get evaluated. And it could be that that person may need a colonoscopy earlier than what the recommendations would suggest, but the symptoms are what is the driving force there. And so I was asked to talk a bit about colon cancer treatment. And so we talked about screening and prevention and so forth. And I think that's the focus of this meeting. But the good news is that for treatment, we have treatment even with advanced cancer that is very successful. And the cure rate is determined by stage. And early stage cancers that we operate on, where the tumor is confined to the bowel wall, have a 90% chance of cure or greater. And so if it's a stage 2, meaning full thickness of bowel wall invasion, it may drop to the 75 to 80% range of cure rate. And if there's lymph node involvement, patients may need chemotherapy and the cure rate drops a little bit, but still, the cure rates are high. And so part of the indication to find this early is if ultimately they do come to surgery, the earlier they're diagnosed with less symptoms, the earlier the stage is, and the better the prognosis is, and maybe there won't be such need for additional treatment afterwards, which we're going to get to. And so people ask me about colon surgery. I'm not going to give videos of how we do operations. I don't think that's appropriate for this group. But to summarize, the colon is the large intestine, and it goes around the abdomen there in an upside-down U-shape in the darker color. And for cancers that are on the right side of the colon, they commonly present with anemia because they don't cause a blockage, and people don't see blood in the stool because it's digested. And somebody comes in weak and kind of tired, and their hemoglobin in Dr. Kondash's office is 7, and they get screened. For tumors that are further downstream, they may have more of a change in bowel habits or bleeding that one recognizes and so forth. But where the resection is performed is based upon the figure on your left, which is the blood supply. And so we take a whole segment or side of the colon with all the lymphatic drainage and put the bowel back together. The question that I'm asked first, do I have to wear that bag? And am I going to have normal bowel function afterwards? The role of the colon is to reabsorb water and store stool. It serves as a reservoir. So there's no role for nutritional absorption, and somebody can have their whole colon removed and digest food normally and have normal nutrition. It may change their bowel habits, but we can remove 3/4 or more of the colon, and people can still enjoy fairly normal bowel function with that. So you can take out large portions of the colon, not compromise someone's nutrition, and the extent of the resection is based upon the anatomy. And how the symptoms present depends upon where the tumor lies in the bowel. This is just a figure of an open operation, but you can see that we're removing the bowel, which is the darker color area, and taking the lymph nodes, which is the leaflet of mesentery leading up to the bowel. That's important for staging because those lymph nodes tell people like Dr. Peters and Dr. Sabuto what we need to do afterwards. And so we have to do formal staging at the time of surgery to remove the lymphatics around the bowel because that's important for the staging. We can put the bowel back together again safely. And the leak rate for bowel being rejoined at the time of surgery is probably less than 2%. And so we don't see that too commonly. There's ways that we can sew it, and there's ways that we can staple it, but we can rejoin the bowel after a resection, and people can enjoy relatively normal bowel function early on after surgery. To go through an operation like this requires a bowel prep, so you come in after preparation like you have for a colonoscopy, and we have all the cards in our favor, and I'll talk about the differences between emergent and elective surgery in a second. But if the bowel is properly prepped and there's no obstruction, we can perform resections with rejoining the bowel back together and safely. Usually this is a 3-day or so hospitalization and a pretty rapid recuperation. People are on liquids when they wake up. They're on regular food the following morning. And because of newer techniques in surgery, we move them along, patients along more quickly, and the recuperation is rapid. Now, this is just an example of how we can rejoin the bowel back together again in the pelvis. One of the challenges for us is rectal cancer management. And so if the tumor is far down in the rectum and one imagines the pelvis being funnel-shaped, if the tumor is low in that funnel, there's cancer that could be approaching maybe the sidewall or the distal margin. And so they're challenging cases, and that's those cases we rely on the help of Dr. Sabuto and Dr. Peters preoperatively to help the tumor shrink so we can perform sphincter operations, sphincter preserving operations. We have devices now that we can actually place inside the rectum, and then we can staple the bowel back together again and not have to do a hand sewn anastomosis, joining the bowel deep in the pelvis. And even with cancers in the terminalmost aspect of the rectum, more often than not, we can perform a sphincter preserving operation. And so I would say that less than 3% of patients with colorectal cancer will require a permanent colostomy, which is how things are done generally these days. And the colostomy, which is where someone wears a bag that drains the stool, it's sewn to the abdominal wall of the bowel, that's reserved for the patients with a locally advanced cancer that may involve the pelvic floor or the sphincter muscle or the muscles of that maintain continence. So we generally do not have to perform a permanent colostomy. So to summarize some of the things that we do, we remove polyps. A colonoscopy and polypectomy removes polyps that maybe prevent cancer from arising. A 2-centimeter polyp, like Dr. Stopper had, has about a 30% chance of harboring a cancer. And as it gets bigger, that rate increases. And so commonly, we do that as an outpatient, and that's a pretty safe thing to do. Sometimes for more radical or more advanced cases, we do open operations with the incision, like you saw there. And more commonly these days, we do laparoscopic or robotic procedures, which are less invasive, and therefore they're done through smaller incisions, and patients recuperate more quickly. What we hate to see is emergent cases, because in those circumstances, we don't have all the cards in our favor. And that is when there is perhaps a blockage or an obstruction that leads to an emergent operation. Maybe someone has a perforation of the tumor with peritonitis, or they're actively bleeding and we need to intervene right away. In those circumstances, it's generally a more advanced cancer, and they're more likely to have at least a temporary colostomy, depending upon the findings. And for smaller tumors that are in the rectum, we can actually use microscopic instruments and remove the tumors transanally. And with all those approaches, the complications rate should be low. I've been doing this now for 35 years, and I can tell you, sorry, that's me. It's tomorrow's or match days this week, so this is what people call me. But the reason we have better results now than we had 35 years ago is the team approach. And in years past, it was a radical operation and hope you get it all and let the chips fall where they may. But now, with selective staging ahead of time and the help of our colleagues in medical oncology and radiation oncology and early screening and detection, we are seeing much better results, not only from finding cancers early, but even with the advanced cancers having more outstanding results. So the key is this type of team approach to achieving better outcomes. I'll be happy to answer any questions when we finish. I hope that suffices. Amber, you go? I think that's my last one.
Hello, everyone. Thank you for having me. My name is Amber Sabuto. I'm a medical oncologist and hematologist. I work at Hematology Oncology Associates in Dunmore. Thank you, everyone, again, for your touching stories. I think it's, again, really important just to emphasize that this is real. It can happen to anybody. And we want to prevent you from ever needing, most of the people on the stage. So spread the word, push the people you love, do what you need to get everyone screened. So whenever as a team we are coming up with our plan, whether it's colon cancer or rectal cancer, the stage is really important in everything that we're deciding to do and how we approach it. Different cancers are staged differently. With colon cancer, the depth of invasion into the wall is what we're really looking at, and whether or not it's involving the lymph nodes that will normally drain the colon. So you could see in the picture, when we're having someone go from a polyp to a stage 1 cancer that's small, that's locally advanced, and then as soon as it's progressing in stage, it's getting deeper and deeper into that wall. And on the opposite side of that wall is where you have the blood vessels, where you have the lymphatic drainage. And that's where the cancer cells have the opportunity to spread outside of the colon into different parts of the body. So when we're talking about any care for any type of cancer, I always tell my patients there are really 2 goals of our therapy. One is to treat the cancer where it's at. And oftentimes that's, with what we're doing in the operating room with Dr. Bannon. Sometimes it's with Dr. Peters and the radiation. And oftentimes where I come into play as medical oncologist is helping prevent the cancer from coming back, helping prevent the chance for those cancer cells to show up somewhere else. Whenever we're talking about our therapies, there are different ways you can do treatment. Sometimes, as Dr. Bannon mentioned, surgery is up front. Someone comes in, they have an operation, they come home after their pathology is back. We discuss, what are their odds for this coming back, and do we have to do anything else? Sometimes with different cancers, now we've taken different approaches, and we know that if we could shrink the cancer, before going to the operating room, by either doing chemotherapy in the form of pills with radiation therapy, we have the chance to shrink that down to hopefully make things a little bit easier for Dr. Bannon in the operating room. We have switched our process, especially in the form of rectal cancer, where now oftentimes we're doing everything up front. It used to be some chemoradiation, surgery, then more chemotherapy. Now we're switching to doing everything up front, and a lot of times I think we're seeing that the cancers are completely gone by the time they get to the operating room, which is obviously, beneficial for the patients in terms of the surgeries they have to have in their recovery. Other situations are chemotherapy, and the technology we have and advances are to make either the quality of life or how long someone is living longer. We don't always have the chance for cure. We can't always get rid of all of the cancer, but what we do hope and what we're getting better at is not only prolonging people's life, but giving them a good quality of life at that. Again, when we mentioned, the stage and why that's so important is because you can see the survival rates, and the survival rates from the cancer in a stage 1 cancer is between 90 and 95%. And that is not with ever requiring what I do with chemotherapy. As you go on to stage 2, stage 3, you see that number drops. So that's why it is so, so important. Again, I know we're emphasizing this a lot, but the earlier you catch this, the better off you are. I kind of have a dual role here because, yes, I'm a medical oncologist, but I'm also a hematologist. So I can't tell you how many patients I see a day for iron deficiency. And in women, we often blame their cycles. We often blame a million other things. But you really have to have that conversation with your physicians, and you really have to push people to get looked at, because I can't tell you how many people I've seen that they've had their cycles blamed for years and years and years, and they never went for a colonoscopy. And it wasn't, just their cycle that caused their iron deficiency. So getting screened, making sure you're advocating for your own family members, for yourself, to really catch this earlier and to, have your chance at cure much higher. So oftentimes with the colon cancer, like I said, stage 1, we're doing surgery up front. Usually there's no chemotherapy or radiation therapy afterwards. Stage 2, most of those patients can deal with surgery and no chemotherapy. There are some higher risk individuals where we do offer chemo. And stage 3 and beyond, you are usually discussing chemotherapy or different medications that I have to offer patients. With the chemotherapy options, I'm not going to bore you too much with this. I think the big deal is, first of all, this chemotherapy, it's old school chemo. It has been the backbone of our treatments for many, many years. But where the chemotherapy may be similar, what has changed is our ability, to treat the side effects. So chemotherapy today is not what chemotherapy was years ago. I would say with this chemotherapy, I have a lot of my patients that are still working. They're getting chemotherapy, they go home, they feel relatively well, maybe they're tired for a day or two, but they're not in bed. They're not, secluded from the rest of the world, and they're able to live their life. So yeah, we have medications to help with the side effects. I hope no one ever requires the chemotherapy, but if it is, it's manageable. It is one of those cancers where I think the patients could do very well. With the chemotherapy that we give, essentially with this backbone, you can get an infusion that goes over about a 2-day process. That's usually given through a portacath, which is inserted in the chest wall. Or there is a pill type of chemotherapy. They become the same drug in your body, and just, sometimes the infusion is better for some patients versus the oral chemotherapy. Where our world has drastically changed is that we are getting so much better at figuring out what makes a cancer a cancer. For a cancer to become a cancer, it has to start growing. What happened in that process where those normal cells started growing quickly? Did the cancer cells start to hide from your immune system? And is that how it escaped and just started doing what I wanted to do? I'll tell you, the number one question I get in my office is, can I have Keytruda? It is literally what everyone's asking me every single day. And it's a wonderful medication. These immunotherapy medications have changed our world. When a cancer is becoming a cancer and hiding from your immune system, the cancer cells essentially are putting on a camouflage and allowing your immune system not to recognize that it's there. these immunotherapies take off that camouflage and they really allow your body to fight off the cancer. It is not for every cancer. We know, there are certain subtypes of colon or rectal cancers, there are certain types of GI cancers and other cancers where it is very useful. But we're getting better at figuring out when and where to put those medications. We also know a lot with colon cancers and rectal cancers, we've figured out what have made these cancer cells cancer. And are there proteins that we know have turned on? And we can turn them off with very targeted therapies. The more targeted our approaches get with chemotherapy or systemic therapies, typically the better our response rates are and the less the side effects. So it is an ongoing, changing world. We've had so many medications over the past decade that have come out and are going to come out and help us fight these cancers, and it's really a remarkable time to be in medical oncology. So that's essentially, I think, and just, again, talking about the side effects. So, yes, everyone's going to be a little bit tired. It could lower your blood counts, but oftentimes patients' counts go up because they're no longer bleeding. You have a risk for infection. That's relatively low with this chemotherapy. Some nausea and vomiting, but again, our medications are wonderful at really preventing and or treating that. These regimens that I discussed, hair loss is not a common side effect. We do talk about some numbness and tingling, but that's what we're here for. We're here to make sure that it's working for our patients and that they're tolerating treatment well.
Thank you.
Thank you, Amber. Thank you for having us. I want to echo some of the panelists. It's a privilege to be here with all of you. Amy and Matt, I think your testimonials, again, what Dr. Bannon was saying is very powerful, one from a prevention perspective, one from going through these treatments. It's very enlightening, even as a cancer doctor, to hear these things. And of course, my good friend Gail and Alessandro, they're wonderful friends of ours. And, none of us are over his passing, but I think we're going to use that to encourage these types of things to get the word out for prevention. It's been said perfectly well, I think, by Dr. Kondash and Dr. Bannon and others about the importance of screening to keep you out of our offices, as Dr. Sabuto says. So I'm going forth, clean up, so I have no problem with brevity at all. I will be brief and save a lot for the question and answer. Part of that's because the radiation oncology aspect can get very technical very quickly, and I don't think that's the purpose of this panel. But I think, as was said earlier by Dr. Bannon and others, the role that I like to contribute to is to help stage the patient and really to, this is a real team effort. By the time someone comes to the oncology clinic, they've been vetted out already by their primary care doctor. They've probably seen their GI doctor. They've definitely, if they have a diagnosis of colorectal cancer, going to meet with colorectal surgery, Dr. Bannon and his team. Almost certainly have met with the medical oncologist and the radiation oncologist, and we all really come together because we have slightly different roles to play. But the big thing is, we have to determine, as Dr. Sabuto was saying, is the cancer localized or is it not in the place where it started? Is it localized or metastatic to other organs? That's key. The other thing that we touched on earlier with the anatomy is colorectal cancer can be confusing if you're a patient because we treat colon cancer and rectal cancer slightly differently. Let's see if this slide advances. There we go. Dr. Bannon has already shown this slide, but the majority of colorectal cancers are in the colon. And in the colon, surgery is the mainstay of treatment. You need surgery basically all the time. And usually you do that first, and hopefully you do it when it's a very early stage. When the cancers get down towards the end of the GI tract, the rectum is the last part of the colorectal tract. Often radiation oncologists play a role in cancers there because that's where the bony pelvis gets very narrow. And getting wide margins and getting around the cancer there becomes more difficult. The last part of the GI tract is the anus, which we're not talking about tonight. That's treated even differently. Anal cancer is treated differently than rectal cancer or colon cancer. But we make these distinctions because the doctors that you meet may have a different role slightly based upon where the cancer is. So in rectal cancer, a few brief comments and then I think I'll be done. Rectal cancer radiation treatments are often used before surgery, generally along with chemotherapy. And the goal of that is to reduce the size of the tumor and to help facilitate surgical resection. In the earliest stages of rectal cancer, usually stage 1, oftentimes radiation and chemo is not needed. Dr. Bannon and his colleagues can go in and remove it. with minimally invasive surgical techniques, and that patient likely does not need any other, we call adjuvant treatments or helper treatments. Why do we use radiation in rectal cancer? Because if you have a disease that's T2 or higher, meaning the cancer has gone through, I like to think of the GI tract as like a garden hose. There's an inner wall, there's the inside where the stool is, and just like a garden hose where the water is, and there's a thickness to the colon. So if it's confined to the inner area, then you're not going to need radiation or chemotherapy. But if it starts to go into the wall or through the wall, that's when those stages, chemo and radiation, can be helpful. So the radiation's role is to reduce the chance of it coming back right where it started. And when it does that, it helps the patient live longer. Radiation therapy along with chemotherapy can hopefully enhance surgical outcomes and facilitates an optimal cancer operation in rectal cancer. Also can provide symptomatic relief to patients. Many patients that come to us with rectal cancer specifically have symptoms. They're having difficulty going to the bathroom. They may have blood in the stool. They have pain going to the bathroom. Usually when we get them started on treatment, they start to feel better pretty quickly. Radiation therapy can be done a variety of different ways, so I'm not going to get into the details, but it's basically a beam of energy. So we call it local therapy, unlike systemic therapy like chemo or immune therapy that goes throughout the body, and that's important because if there's a cancer cell that broke away outside of the primary, only the systemic therapy gets it. Surgery and radiation are directed to a place. So if I'm treating the rectum, the effects, good and bad, will be limited to the rectum. If I treat the lung, it's different. Sometimes colorectal cancers can move to other parts of the body, pretty much anywhere. It can move anywhere. So we may be asked to treat tumors in those locations for symptomatic relief. But essentially, the patient doesn't feel anything during the treatments because we're using high-energy X-rays most commonly or other subatomic particles that we can deliver at very high energies to try to kill cancer cells. And really, that's my last bullet point, is that we were asked to touch on side effects, but the side effects of radiation are going to depend entirely on where I point the beam. So if I pointed at the rectum, the side effects are going to be different than if I pointed at the belly or the lung or the brain or the throat or wherever it may be. And so generally I'll counsel a patient, and it becomes pretty obvious, if I'm treating the abdomen, you're going to have abdominal side effects, et cetera. And so the key things to kind of touch up on are multidisciplinary team approach once you get to our office, but hopefully, like we're saying, I'm wearing this band in honor of not only Alessandro, but the Cancer Institute. Please talk to your friends and family and community members, just get a screening test. I think Dr. Kondash pointed out there's so many ways to do it. Some are considered a bit better than others, but any screening test is better than no screening test. And I think that's all I have to say. Thank you.
Thank you, Chris. I'd like to wrap up this section with just a few remaining slides. What can I do to reduce my risk? It's a question that I ask, that you may be asking. There are things we've already covered. One is know your family history. Share that with your doctor. And don't be afraid to check again, because family histories can change. I'm in my 70s. When I was in my 50s, my family history was fairly different. So know your family history, share it with your family doctor. Eat a healthy diet. I've already mentioned things like fiber in your diet. Your mother was right. Eat your vegetables. Exercise and maintain a healthy weight. Those are also factors that can help reduce your risk. Avoid tobacco and excess alcohol. And even if you're not symptomatic, get screened, because screening is the best way to prevent colon cancer mortality. And as we've heard tonight, it can also prevent colon cancers from being progressed or actually developing. So screening is important, even for people who feel perfectly well, at risk. If you're 45 and older, talk to your doctor about being screened. So with that, that will end our formal presentation. We have had some questions submitted during the registration process, and if I find my notes, I'll bring those up and we'll try to answer some of those now. There's also, should be the opportunity to address additional questions that you may have. One of the questions that we got online was, what are some of the possible explanations for why colon cancer is increasing among young people? Short answer is, we don't have a real good answer. The more complicated answer is, as far as we know, the risk factors for colon cancer in people younger than 50 are pretty much the same as those for everybody else. Couple of differences, perhaps. Metabolic syndrome, where patients may have high cholesterol, high blood pressure, high blood sugar, and a bit of extra weight around the belly. That's an increasing risk factor, and that seems to be a bit more common in the younger patients. Obesity itself, diabetes, the rates of those conditions are increasing in our younger population. So those are important things to have that population be aware of. Excess consumption of sugar-sweetened beverages. We all like a nice, refreshing, I won't mention a brand name, but that's apparently or recognized as a risk factor as well. And one thing that may tie this together is a change in the microbiome. The bacteria and viruses that live in our gut may be influenced by the things we eat and drink, and also past exposure to things like antibiotics, so that our gut microbiome may be changing, and there's some active research looking into what effects that may have on chronic inflammation and the effect on the colon and colon cancer risk. So that's my best explanation for why rates may be going up among younger folks. Anyone else on the panel have thoughts? Okay. A related question is, why are the rates of colorectal cancer high in Northeast Pennsylvania to start with? And I sort of fall back to those same risk factors. We know that the prevalence of former or current cigarette smoking is higher in Northeast Pennsylvania than the US average. We do have high rates of obesity and diabetes in our community as well. Those are probably contributing. I don't believe that genetic syndromes are unusually common here, and I'm not aware of other environmental factors that might contribute to the high risk. And as I've said before, the disparity in risk is shrinking. Yes, we have higher rates of colorectal cancer in Northeast Pennsylvania, but it's not as high as it was 25 years ago. So there is some good news in that. And as Dr. Bannon mentioned, rates are dropping nationwide for all ages combined. The only difference is that younger group. So there are good news in the story. We're doing better with treatment as well. Any other thoughts on risk?
One clarification, and your points are right on target, as always, Sam. The increased rate of colorectal cancer in our area is age adjusted. So even though we
Yes.
do have an older age group in our population, that alone does not explain the increased risk.
Right, thank you. What are the top things a person can do to reduce their risk? Well, I think we just covered those, including that final slide. Now, here's a question that I'm going to pass to the panel. Freakonomics Medicine podcast with host Bapu Jena argues that colonoscopies are heavily used in the United States, much more so than in the European Union. What do we think about that? What's the risk and benefit? Or can we weigh in on the risks and benefits of that? And I'll look to Dr. Bannon first.
Well, I'm not sure why the rates of colonoscopy screening are lower in other countries. In industrialized countries, they have the same screening recommendations as we do. It may have to do with socialized medicine and cost and availability. But I think that what we should focus on here is what's the best science for our population and be the leaders in screening and early detection. And there may be different rates of colorectal cancer in other countries, and we do see that. And maybe it's because of different environmental factors, different types of diets and lifestyles. So there are certain areas where colorectal cancer in the world is less common than we see in the United States. But in European countries and industrialized countries that have similar type diets and activities as we do, I think the rates would be pretty similar, and I think that there are other social factors that may affect colonoscopy screening.
But do you agree that the risks of colonoscopy screening are so small that that shouldn't be an important factor for us to consider?
Yeah, risks for screening are extremely low. It's done very safely, it's done under anesthesia. The risk of bleeding or perforation, meaning a rupture of the bowel during the procedure, is less than 1 in 1,000. And usually when there is one of those complications, it's because of someone trying to remove an advanced adenoma or a complex circumstance. So it's very unusual for someone to have a significant complication from colonoscopy. It is a safe procedure.
Thank you. I'm taking mesalamine, I think that's how it's pronounced, and have been for years. I'm close to retirement. I'm concerned that this medicine may not be covered by Medicare. Is there an alternative that is effective and maybe less expensive? I don't have an answer for that. Dr. Bannon, do
So
you?
mesalamine is a 5-ASA agent. It's used to treat inflammatory bowel disease and not cancer. There's lots of different forms of mesalamine, and there's generic forms that are available today as well. And so it's the generic form is relatively inexpensive, and it's a medication that's been around for decades, much longer than I've been in training. And in fact, we are using more of the biologic medications that you may hear advertised, like Humira and Remicade and Skyrizi and Entyvio and so forth, which are more advanced treatment for inflammatory bowel disease, ulcerative colitis or Crohn's. And although mesalamine is still a mainstay, it's relatively inexpensive and it's available in a generic form. So it shouldn't be a problem for that individual, and it's not related to cancer.
It's not related to cancer, but inflammatory bowel disease is, and that's probably
Slightly
why
increases the risk, yep.
the issue comes up. Thank you. There's a question that we may have already answered, but I'll read it anyway. When should someone be screened if they have a sibling with colorectal cancer diagnosed at age 45?
Well, my answer is 10 years before that cancer was diagnosed. And I think that's probably standard. Would you agree?
Yes.
Yeah.
What if I have symptoms but don't meet the criteria for screening? My first reaction is, if you're symptomatic, then you're not eligible for screening, because screening is by definition among people with no symptoms. But if you have symptoms, then I think you talk to your doctor about the symptoms, and if appropriate, have a diagnostic evaluation to get to the bottom of the symptoms. Any other thoughts on that?
No, that's one of the points that I mentioned earlier. Call Dr. Kondash.
All right.
And it may not be that you have cancer. Hopefully it's, you could have a GI bug, but if there's symptoms, get it investigated before it lingers too long.
What is the KRAS mutation and its role in oncogenesis? And does the prevalence of KRAS mutation correlate with the increasing risk of colon cancer in young folks, those under 50? Dr. Sabuto.
So the KRAS protein is one of those proteins that do tell a cell to turn on and to grow. So whenever we have a colon cancer, we are typically sending off these genomic profiles to see what mutations are specific for that cancer. Oftentimes that could be on the tumor itself, or it could actually be done oftentimes with a blood test, with testing for the circulating tumor DNA. But with KRAS, when you have this mutation, what's happening is that gene is then going to be activated, and you are going to cause more and more cell growth, which in that situation is the reason that cancer became a cancer. It's important because there are certain medications we use for colon cancers that work on different pathways, and where this occurs in the genome is downstream of that. So if you have a mutation that's turning on the cancer here later in the pathway, and something that's treating the cancer kind of further up before it gets to that, it makes those mutations, those patients who have those mutations, more resistant to different types of chemotherapy. So in our standpoint, it just tells us, don't use certain medications like cetuximab, panitumumab. But the good side of that is that we do have drugs that are starting to target these mutations. The thing that becomes difficult is you could have mutations at different sites in these proteins, which could make some drug therapies effective, or sometimes it doesn't have effect. But I think that just goes again, towards that whole everyone's cancer is becoming, very personalized with their treatment plan and figuring out exactly, what is making it grow. And that KRAS mutation right now means you could be resistant to more treatments or the cancer could grow faster, but hopefully in the future, it's just another pathway that we can target with different therapies.
Do we know anything about the prevalence of KRAS and younger folks?
I haven't seen it directly linked, I believe the prevalence is very similar. It's
Yeah.
about 30 to 40% of patients who have a colorectal cancer, and I have not seen an increased rate of that mutation in the younger populations.
Right, nor have I.
Broadly, Sam, Dr. Sputo's right on target, but we're learning more about tumor biology. And as we are, we can tailor the treatment more to that individual based upon variations of the type of tumor they have. And different types of colorectal cancer may have slightly different biologies and therefore be more susceptible to certain types of treatment. And we order a lot of different tests now that help Dr. Sabuto tailor her therapy to improve outcomes.
So to get back to the question, KRAS isn't the explanation for
I don't believe so,
increasing
no.
risk of colon cancer in people under 50?
No.
At least not that we know. Okay. What resources are available for individuals who don't have insurance and need to be screened? Well, I could suggest contacting my organization, the Northeast Regional Cancer Institute. There is a navigation program that can assist with navigating patients to be screened for colon and rectal cancer. I won't go into all the details, but you can check at the table outside or call or look up the Northeast Regional Cancer Institute website and get some more information about navigation.
Yeah, and most health systems, ours at Geisinger included, has people that can help. So when somebody comes into my office and they see and sit in front of me, things are taken care of before they reach me. I don't know who has insurance or not, and we treat everybody the same. So when somebody comes in and doesn't have insurance and has symptoms, that should not be a reason not to get checked. Come in, we have people that will help and get things taken care of. I do see that isn't a problem and too often leads to, a late diagnosis, and that's a tragedy, and so come in, there are people within our system that will help get them screened and taken care of.
So not having insurance shouldn't be the barrier. Don't hesitate, speak to your doctor, get in the system.
Extremely important point.
And the last question I have written here is, what should future oncologists focus on when thinking about treating and detecting colon and rectal cancer in the next 10 to 15 years? So dust off your crystal ball and tell us what you think about treatment on your side, Dr.
Yeah.
Sabuto, and thoughts?
So I think it goes back to the fact that all of our cancer care is becoming individualized, and we're able to tailor our treatment to the patient, to their tumor. We're able to detect these mutations in so many different ways. Like, we used to just have that original pathology to go on. And now with these tests, it's a blood test, and we can test for the DNA, just on a blood test that's sent out from the lab, and we can pick up, is there a mutation now that wasn't there before? A lot of times what we're seeing is mutations that maybe aren't treated in colon and rectal cancer, but are, targets for therapies in ovarian or breast cancer. And oftentimes we're talking to those drug companies, can we get the drug approved? And I just think that's the focus of the future of oncology care. And it's a very exciting time to be in this field, just because it's changed so drastically over the past few years, and I think it's just gonna continue to blow up.
Anyone else with other thoughts?
Similar on the radiation oncology side, because we're having better ways to target tumors. So a lot of what I do is finding the target and shooting it, right? So if the more accurate are at doing that, the better the outcomes are gonna be for the patient. Also, dovetailing off what Dr. Kondesh said earlier, I think that the screening tests, particularly with the DNA screening tests such as Cologuard, as they get better, you're gonna be picking up, in addition to the inherent testing parameters that Sam, you spent a whole lifetime discussing, sensitivity, specificity, PPV, et cetera. That's gonna get better, the patients to be able to, go to the bathroom at their house, be able to pick up a lesion, to get you into Dr. Bannon's office, screen you, or get a diagnostic test to pre-invasively remove something so they don't have to ever get to the oncology clinic. So I think there's gonna be a ton of information on that. And as chemotherapy and biologic therapy and radiation therapy get more targeted, the therapeutic ratio or the benefit that you cause versus the side effects that you cause, that widens, and that leads to a better patient experience.
And I think the more we learn about tumor biology, there's going to be different forms of treatment that are going to be indicated. When I was just starting years and years ago, anal cancer, which is a different type of tumor, a different biology, was a surgical disease. It was treated with radical resection and a permanent colostomy. It's no longer even a surgical disease. We are involved with diagnosis and surveillance, but it's treated with chemotherapy and radiation, and the results are so good that the vast majority of patients don't need surgery. Step forward now, 30 years later, and we're treating rectal cancer with preoperative radiation and chemotherapy. And I would say close to 20% of the cases of rectal cancer have a complete pathologic response, meaning that when they finish their treatment and I take a look, there's nothing left. And so we are in select patients keeping them under observation with watchful waiting and careful surveillance and not putting them on radical operation. And it could be that with that treatment alone, with chemoradiation, they're cured and may not need a radical surgery. And as those treatments continue to evolve and improve, I think particularly for rectal cancer, we'll be operating on less of them. And I think from a surgical perspective, we're learning how to do things better and look differently every day. And so with more minimally invasive techniques, with better understanding about pathophysiology, with better anesthesia and teamwork, I think our complication rates are much lower than they were in years past, and survival rates from surgery are higher. So technical advances seem to keep developing, and we have to keep up with it.
Great. Well, those are the questions that I have that have been forwarded in advance. If there are any remaining questions from the audience, we could still take those now. I think we have some microphones. Are the mics on?
Hi, thank you for speaking tonight and sharing with us. Everyone, thank you for the stories. You mentioned a family history of colorectal cancer as increasing a risk, but is family history of any other types of cancers also associated with an increased risk of colorectal cancer?
It's primarily colon and rectal cancer that increases risk. If you think of the hereditary syndrome of Lynch syndrome, there are a number of other cancers in that, including endometrial cancer, cancer of the uterus, ovarian cancer, cancer of parts of the urinary tract, even some brain cancers are in that larger Lynch syndrome mix. So I guess the bottom line is I would share information about a cancer diagnosis with all of my family members and encourage them to share that with their physicians so they can make the best informed choice and recommendation for screening and risk mitigation. Other thoughts, Jane?
And Allison, I think there is somewhat of a correlation between risk for colorectal cancer and breast cancer. And I see in my practice many patients who have both. And it's not like it's spread from one place to the other, but it's two separate primaries. So I certainly make sure that all of our patients that have been diagnosed with breast cancer are up to date with their colorectal cancer screening. And I also make sure that all of our patients that have been treated for colorectal cancer are up to date with their mammograms and a proper follow-up. Some of that may be anecdotal, but we see it far too often for it to be an accident.
Yeah, I was just going to say that similar, in terms of our breast cancer patients, they're often the ones who have had the genetic testing. 'Cause I think it's a well-known world where, we know exactly who to send for this genetic testing. And I can't tell you how often those test results come back with different mutations that are not necessarily your BRCA mutations or the mutations associated with Lynch syndrome, but there are other mutations that also have colorectal cancer, risk factors. So when we're seeing those patients in our office, that is part of the, once we've gone through that genetic testing results and gone over to them what the screening guidelines are, we're oftentimes sending them, for colonoscopy screening too.
And the MyCode system at Geisinger is one of the largest genomic programs in the entire country. And so many of our patients undergo tests. I was recently in to see an orthopedist, and they say, Jay, do you want to participate in this? Sure, boom, and they draw your blood and so forth. And, you know, there's hundreds of thousands of people already in this program, and it will continue to expand. And I think that is going to really bear fruit as we look forward to determining risk of not only cancer diagnoses, but other types of diseases. So I think it's a great thing that Geisinger is doing now, and I think that there's a lot that's going to be learned from that.
Right. Other questions from the audience? Yes?
Good evening. I have a comment and a question for the panel. I am a colon cancer survivor. 10 years ago, I had 2 massive tumors removed. I am grateful to Dr. James Roach, who did my surgery. I had 2 open colectomies, 9 hours each, and 17 obstructions in the emergency room. And then I met Lisa Thomas. And Lisa is my oncologist, Dr. Thomas, and she takes care of me. And we do tumor markers annually and a CT scan because of other complications from the surgery, nodes in the lungs, and other issues with abdominal aneurysm with Dr. Brian Mott. So I know about being alive. I'm still here 10 years later. And the reason why I'm here is because I believe in medical science, and I believe in my doctors and their plan of action. I have a wonderful physicians at the Wright Center for Primary Care, and I have a whole list of specialists who treat me for all my related conditions. So I congratulate our survivors that spoke tonight. Keep the message going. Bang the drum. Be loud, be bold, be brave, and spread the message to everyone at work, in your family, and in your church, and in the community. So that's my comment. Now, my question is sort of to Dr. Bannon, are they still doing the laparoscopic colon resection?
Sure, very commonly. And I think that's done more often than open operations by a long shot
Yeah.
these days. But it depends. I think that it's up to the patient and the surgeon about how things are handled. But in general, using a minimally invasive approach, laparoscopic operations are often done robotically now. My partner, Dr. Urchinger, who's behind us, is an expert in that. But minimally invasive surgery is the way many or most of the colorectal cancers are done, not only locally, but throughout the country these days.
See, with me, they started it, but Dr. Roach said he couldn't get the entire tumor out. We had to switch it. And that's what happened.
That's the
All right.
judgment at the time of surgery, and sometimes that's the
Yeah.
appropriate thing, yep.
Yeah, and it would make it much easier. I was in the hospital 5 days for each surgery and then coming home. And then I sat in the chair and I said, am I going to sit in the chair at 55 years of age and die, or am I going to do something about it? And I got a team together, a medical team, a physical therapist team, a dietitian, what I can eat and what you can eat. One of the big things after the surgery is your diet, because that controls how you go to the bathroom. And what you eat is what you are. So if you eat high fiber, watermelon like I do, fruit in the winter, you won't have serious complications. I had gummy chews, I had laxatives, I had everything until I went to bananas, watermelon, and whole wheat breads and high fiber foods. And I just want to ask this question because I heard it mentioned briefly before in the conversation. The area, northeastern Pennsylvania, Scranton and Wilkes-Barre, we have a lot of coal mines, and we have dumps with trash and gases in. Has any study ever been done on that relationship to cancer rates in northeastern Pennsylvania? like research, saying certain neighborhoods have open mines underneath them, and you're breathing in all that toxic mine gas at nighttime while you're sleeping. Or even with the landfills, people see things coming down the street, they don't know what it is, coming out of the sewer. And any relation or correlation between the high numbers of northeastern Pennsylvania and environmental sciences and technology.
I don't think we've seen a clear relationship between those types of environmental exposures and colon cancer, certainly, or most of the other cancers that we've looked at. That's not to say that it's not an important concern to the community. And anytime we have environmental exposures that are noxious, that have a health risk, something should be done about that.
Yeah, like radon in the basements and everything. And finally, I want to thank the dean. I know her because I'm a standardized patient here at the Geisinger Medical School, and I share my knowledge and show them my scars to all of her students in special groups and studies.
Thank you for that.
And I hope she shares your program with all the students, that they can watch us when they have time and convenience and learn more about colon cancer and the changes. Thank you very much.
Thank you.
Hi, good evening. I'm Mayor Brown, Mayor Wilkes-Barre, and I just want to say thank you to the panel that's here tonight. You folks volunteered your time, and it's valuable what you presented tonight. But I'm the mayor of Wilkes-Barre, but more importantly, I'm Amy's dad. And when we put this program together last year, it was called Amy's Story. And it started building, and I was so happy when Becky and the Commonwealth, the Geisinger School of Medicine said, let's do it in Scranton also. And the team that was put together has been working on this literally for months. And those of you that are here today, I just want to thank you, everyone that was part of the team we put together. But my message is, as Amy's father, if you have someone you know, a family member, a child, someone that is having some of these symptoms, please take them to the doctor. I do not want your children, your family members to go through what my daughter went through, okay? It was a terrible year we put through, but Amy is now cancer-free. I'm sorry, Amy, to make you cry. She's cancer-free. Full time, but the main thing is she's living a normal life without cancer. So please, folks, get a colonoscopy. I'm getting one next Wednesday. I'm not embarrassed to say that. And our family got it, you know, her siblings and my wife. So please, folks, listen to the people here today. They're the experts. And I thank you so much, because our goal was to save one life, make one person go for a colonoscopy. What you did today, you're saving more than one life. So doctors, thank you for being here. Geisinger, I just thank you so much. You're wonderful. And the folks that did the testimonial, you're saving a life too by sharing your story. But like I said, as a parent that went through this for a year, it was terrible. But Amy's back, okay? We have Amy back with us. And but thank you so much. And thank you, everybody's here tonight. I really appreciate it.
Well, with that, I'd like to thank everyone for attending tonight, for our panel, for their contributions and discussion, and especially for our testimonials, and to Geisinger for hosting as well. Thank you all, and have a good night.
Thanks, Ted.